Dizziness is a very interesting topic. Writers, academicians, and even clinicians writing about it, just to give you some helpful guidelines on what to do in your clinic, are having a hard time trying to pin it down. It's hard to talk about dizziness because the causes of dizziness are multiple and it's varied. It's one of those vague symptoms that leads you to all sorts of diagnosis. So the biggest question is, how do you write about it, or how do you talk about it in 2 to 5 pages? So that's the first thing I have to tell you. When you open articles about dizziness, try to figure out who's writing it and who is it being written for, and where is the author coming from, or where is the speaker coming from. Along the primary care fields like general medicine and family medicine, we won't talk about childhood dizziness because, for one thing, it's a completely separate thing and it comes with age. Like, if a small kid says he's dizzy, it means something else. If a teenager or a 10-year-old says they're dizzy, it means something else, and the causes are varied. So we'll restrict ourselves to adults. Okay, so this will be general practice, general medicine, and family medicine, and adult primary care. What I can tell you is when you read about dizziness articles or journal articles in primary care journals, what you'll see is dizziness attached to the word vertigo. Why is that so? Well, because it makes things simpler. When you do that, things are a lot simpler. So if you scan the articles, what it will say is, dizziness is caused by all sorts of things. Actually, some people even put vertigo on the title, and I think it's good practice to do that, because if you're going to talk about dizziness and focus like more than half of your entire talk or article on vertigo, might as well say that it's about dizziness or vertigo, or make sure that the one listening to you or reading about it doesn't get confused, and then they start out with dizziness and vertigo, and people will describe it. I think the best way to describe it is this: dizziness is very imprecise. It's difficult to pin down because when people say dizzy, it can mean all sorts of things. In Western English speaking countries, mostly where our textbooks will come from, or your textbooks might come from, if you're in a country using Western books, that would be Canada, the UK, or the United States. When the patient says, "I'm dizzy," a lot of it would mean that, vertigo, the world is spinning, or there's a sensation of movement. It's the kind of dizziness that you see on Western movies or television shows. Somebody gets dizzy and then things get blurry and then the background moves, and that's pretty much what it is. Now, the problem with that is if you ask somebody else in a different country, especially if they're using their own language, which adds to the confusion. When they say dizzy in their own language, it can mean all sorts of things. It might even refer to the problem Westerners or Western medicine encounters when they attempt to write about dizziness. It could mean all sorts of things, like it could be the vertigo, world spinning kind of thing. It could be fainting or almost fainting. It could be feeling imbalanced, and it could be lightheaded. And some communities or populations would have just one word for it, right? Now, what comes afterwards is the article might say, well, most of the time they refer to vertigo, but that's only in their population. That's only in people speaking the English language. And even in those places, if you go to smaller communities, it depends on what the culture of that community is. Now, if you move to another country, then you have to figure out whether when someone says dizzy in their own language, it also mostly means vertigo. And I can suggest to you, in many places, it's not it, okay? Why is this important? Because if you misinterpret or misread that information, then you might end up going in the wrong direction. For example, even if it's just a separate field, like if you grab a non-primary care, non-ENT primary care kind of material, let's say neurology kind of material, then they'll give you a different take on the situation. For example, well, if it's mostly vertigo, then the next suggestion is it's really difficult to use descriptive terms. Then maybe we shouldn't pay attention to near fainting or pre-syncope, because it's hard to come up with an algorithm. It's not important because we cannot use descriptive terms that are misleading. That's one take, but that's the wrong take. Now, the neurologist will say, well, if somebody really faints or almost faints, and you asked and you clarified and it's really it, then that might mean decreased cerebral blood flow, which is diffuse, right? So you fainted or almost fainting. So that's not a benign thing. And if that's happening, you would want to know right away. You won't follow the usual algorithm they present in page 2 or page 3, which would say, figure out whether it's central or peripheral, spend like 5 minutes to 10 minutes doing this peripheral central test. You won't do that, especially if you're dealing with someone with some risk factors. Actually, even if that person doesn't have any risk factors like, age, diabetes, hypertension, if someone really is almost fainting, you'll be worried about decreased cerebral blood flow, and you'll start looking at the brain, circulation, and the heart, and things like that. And the article in the ENT assisted primary care material doesn't talk too much about that kind of pre-syncope, dizziness, near fainting kind of scenario, right? Of course, if you don't think that way, that can easily get you in trouble, right? I mean, it wouldn't be surprising if within the next few days or few weeks, that same person ends up in the hospital with a big stroke, right? So now when somebody says lightheadedness and woozy, it can still be the vertigo, vestibular, ENT kind of thing. But then you think about blood pressure, you think about metabolism, you think about drugs, and you think about psychiatric and psychological. This can also mean like, out of the body, floating, spinning kind of thing. And usually the people with psychological or psychiatric problems would have this kind of thing, Now, motion sickness, it's so obvious, you ride a car and things are moving and then you get motion sickness, and it's pretty much all there is to it. Now, gait unsteadiness would be something else. And again, the primary care article might mention it, but then it will only probably spend about 3 to 5 sentences about it. But it doesn't mean it's not that important. My suggestion is when you look at an ENT-oriented primary care article, what they're saying is if you're in a place where a lot of young adults, maybe not really young, like 20 to 40, can readily access medical care or primary care, and you can easily rule out really terrible causes that would get you worried, then what you're left with is someone who's just complaining of dizziness. And if this is a Western English-speaking patient, then when you ask about it, then they'll talk about moving rooms or spinning rooms and something that looks like or might feel like vertigo, and then you use the article. Okay, so before you use the article, in your head, go through the bad stuff. The thing about these articles is it doesn't have, or most of the approaches don't contain the red flag kind of approach, like the ones you find in abdominal pain. Like, before you start thinking of the benign hyperacidity, it's not going to kill you kind of thing, look for these red flags, and it might mean a big ulcer or a cancer, things like that. It doesn't contain that, so it assumes that you've thought about it, and your 8 to 10 year educated physician mind has actually ruled it out. So you're left with someone who doesn't look like, who is not presenting with a whole bunch of other stuff that would get you worried. It's just complaining about dizzy, and in the Western sense, mostly vertigo kind of dizzy. Okay, so, and it's not going to talk about most of the other stuff already afterwards, after the first page. So that means in your mind, you've already ruled out stuff like, anxious, hyperventilating, somebody with a history of stroke, or somebody who looks like it's about to faint or just fainted, and you're thinking about cerebrovascular insufficiency or poor brain blood flow, or somebody with a cardiovascular disease, or actually it's not just dizziness here, there's a whole bunch of palpitation and chest pain, or somebody who actually has a history of that, someone who has other neurological findings or has a history of neurological disease, maybe even someone with cervical osteoarthritis or spondylosis. Or obviously, you should have ruled out, because it's very simple. Nobody even talks about it because it's pretty straightforward. Someone with eye problems, and when you ask about dizziness, they're actually describing something that sounds like it's related to eye problems, maybe even cataract. Like it's hard to see, everything's blurry. Some people might even call it dizzy, especially if you're in a non-English speaking or dealing with a non-English speaking population. Medications, of course, it's pretty obvious. Somebody visited their cardiologist or their endocrinologist or diabetes doctor, or you did, and you went for the usual current day advice that, you use 2 medications or 3 medications all at once because it's kind of better. But then you're trying to save time because, you're too busy, so you gave the full moderate to high dose right away, and then the patient comes back in describing some form of dizziness. Well, you don't think vertigo, or you don't think peripheral vertigo. You think about the stuff that you did, right? So obviously, so that means you have to use your brain. You have to think about the context. Okay. Now that's the problem with some of the articles. Some of the articles are saying, well, the description is not that important, and just do this. Try to figure out whether it's peripheral or not. Well, not really. That's assuming that you're looking at the particular patient population they're describing. So if we talk about this and you got a history and you got a sense that it's something else, then obviously you should be doing the blood pressure and you'll be looking at the cardiac rhythm or auscultating or doing a screen, psychological screen or psychiatric screen or neurological testing or having the eyes checked. So the initial take, the initial impression, the initial history, and the patient's previous history under your care, since your primary care, you've actually seen this patient multiple times, will tell you whether the article or the lecture about dizziness and vertigo applies to your particular patient. Now, if you don't think that way and you start following the article, I wouldn't be surprised if your patient ends up in the emergency room because of something severe that the article doesn't really emphasize. Or I wouldn't be surprised if the patient ends up getting all sorts of things about vertigo for the next 2 to 4 months and then later gets told that it's actually not an ENT vertigo kind of thing. It's actually something related to the brain or the heart or metabolism or endocrinologic. Again, the first decision whether this is a case that would fit the thing you've read about dizziness and vertigo is very, very important. Now, I really don't like articles in primary care that says dizziness and then talks about vertigo half the time because it's misleading. But when somebody puts out an algorithm, it's usually a vertigo-focused algorithm. Now, when you look at the algorithm, it's all about whether it keeps on happening continuous or it just happens every now and then, and whether something provokes it, and if certain things tell you whether it's peripheral or central. Now, the bottom line is this. Of course, you can just look at the algorithm and just follow the arrows, but it won't make sense if you don't really think about it. Now, look at it this way. The vertigo/ENT kind of thing, your algorithm will usually end up with the big 3 common stuff. Of course, those are not the only ENT vertigo kind of things, but the simpler algorithms will probably end up with benign paroxysmal positional vertigo, Meniere's disease, and vestibular neuritis. Okay? Now, if you look at the other stuff, they're the non-ENT, non-vertigo kind of stuff. Okay, so you have orthostatic hypotension, migraine headaches, which is partly vestibular, but it's also migraine, and psychiatric psychological symptoms, and central etiology, like stroke, brain circulation, and things like that. Now, that's the deceiving part because, when you look at the algorithm, you only see 3 ENT vertigo kind of looking things, and you see 4 non-vertigo ENT kind of looking things, right? But those 4 are big categories. You're actually looking at an algorithm with trimmed branches. For example, orthostatic hypotension. And then it says assess orthostatic hypotension, and that's the end of the algorithm. But what are the differential diagnoses for orthostatic hypotension? There's a whole bunch, right? And some of them are really life-threatening. So when it says assess for orthostatic hypotension and then the branch stops, it doesn't mean it's not important. It doesn't mean it's not going to get yourself in trouble. It only means that the person talking about it or the person writing about it is not too interested in talking about it because that would make the article or the lecture extremely long, right? Vestibular migraine. So the migraine can have a vestibular component. Now that's fairly easy. It's not a big branch, but then the article might say, well, we can't do much about the vestibular part, and that's pretty much the end of the story. Try to manage it, but that's not true. Thing about it is, it's a primary care/ENT kind of article. The neurologist will say, well, you have to manage the migraine because even if you cannot control the vertigo that much, it's still a migraine, right? And it comes with all sorts of sensations, and you have to manage the migraine. Psychiatric problems, psychological problems, it's just one branch. And this is really one of those branches that are terribly managed, right? Because not a lot of people, especially in resource-poor communities, are too interested in the psychological and the psychiatric. Usually, if they sense psychological and or psychiatric, they have a very low threshold in referring to a counseling clinic or a psychiatric clinic because they don't want to mess with it. Now, for several reasons. Now, the primary care people nowadays in managed care situations, especially if you're running a primary care clinic, family med or general practice clinic in a big metropolitan area, you have like 30 to 40 patients in the morning and 30 to 40 patients in the afternoon, and there's not a lot of continuity. It's a fast thing, and you don't have time to do a psychological or psychiatric interview, and obviously you cannot do a lot of counseling there, even if they taught you counseling in your training program. Getting taught how to do it and doing it in training is different from whether your consultants teaching or actually doing it in practice, if they're that busy, right? Anyway, so that's the psychiatric thing, and that's a big thing. If you just treat it as it's just a psychological thing and it's not important. Well, it is important depending on how bad the psychological or psychiatric problem is. Like a panic attack could be extremely disabling, and it can be much worse in terms of impact on the patient's life as your benign paroxysmal positional vertigo or your vestibular neuritis, which would get better in a few days or weeks, right? And yet you spent 5 to 10 minutes doing all sorts of maneuvers trying to figure out whether it's central or not. I mean, if you spend that much for something as benign as that, then probably you should spend that much time and effort on the psychological part, especially if it looks like it's something that's very disabling or it affects the patient's life much, right? Now, the other problem is there's not a lot of mental health counseling clinics or psychiatric care resources in most communities, especially in low-resource communities or countries. So that's not an excuse for you not to do anything and say it's not your fault. That means you should be doing it yourself if you're primary care, general medicine, or family medicine if we're dealing with adults. Now, the central brain stroke, brain circulation category, that's the one you don't want to miss, because that's the one that will give you someone who's dying or with a major stroke 3 days later in the emergency room, and then they'll ask, who's the primary care doctor who saw you 2 days ago? Well, he saw me and he said it was just plain simple benign vertigo, and that's terrible, right? That's the thing you don't want to do. Now, just because it's just one branch and then the branch stops at central etiology stroke, it doesn't mean it's not important. Obviously, stroke, and the word stroke tells you it's very life-threatening, it's very important. Or if there's a red flag, that's your red flag. Actually, there are several red flags. If the psychiatric problem is severe, that's also a red flag, right? If the orthostatic hypotension is a manifestation of something severe as far as the brain and or the heart is concerned, or the kidney is concerned, then that's concerning. It's not a one branch, not important kind of thing, right? Now, before we go to the vestibular ENT vertigo kind of thing, there's actually a major branch that stops. That would be medications. And that's actually a very big branch, especially nowadays, since a lot of people are being told to use several drugs all at once on many chronic diseases. And again, if you're very busy, you just give the whole slew one shot so that they don't need to keep on coming back with you titrating the entire thing. Of course, the geriatricians will tell you don't do that, especially if you have someone who's 60 or over 65. You start low and go slow, right? Now, you'll only do that if you really care about your patients, which doesn't usually or sometimes doesn't happen if you're a charity kind of center dealing with low resource population. Hopefully not. Treat your patients the same way, whether they're paying you, in which case you look so friendly and caring, or not. And hopefully you still look friendly and caring, right? The medication part is also a problematic thing. Why? Because doctors don't want to think about it. Why? Because what do you do? Well, you think it might be medication. Well, actually, you try not to think it might be medication because you're kind of stuck. One guideline is telling you to use a whole bunch of stuff, and you think you need to use it, especially in places where most of the medical industry money is coming out of and usually this happens with low resource countries or communities. Much of the business is coming out of the antihypertensives and anti-diabetics, so they're pushing it, and then you feel like you're doing a disservice to the patient if you hold back on your medication, so you try to use a whole bunch of it, but then something's telling you the patient's feeling dizzy and feeling some adverse problems related to the bunch of medications you're using. But you don't want to think that way because you don't want to stop, decrease, or pull out some of the medications. Now, my advice is be aware if you're biased. And there's lots of reasons why you will end up being biased, like, a frequent visit from a medical industry selling person or representative giving you freebies and telling you if you want assistance in going to the airport and staying in a hotel or whatnot, or if you want assistance with your multi-million bucks conference, it's going to bias you. So be aware of your bias. Then once you're aware of your bias, make sure that it's not affecting your judgment. If it's medication, then it's medication. If it's possibly medication, then think it's possibly medication. Okay, so don't sacrifice your patient for your selfish motivations, right? Of course, that's more and more difficult to do nowadays. I've even heard fairly senior consultants say, well, doctors have needs, and then they present this hierarchy of needs, and we need, well, that's not what it means. It doesn't mean you need the freebies to go abroad because those are that's not what it means. But so be aware of your biases and then control it and take care of the patient. Don't sacrifice your patient for your subconscious or conscious gains, right? Anyway, now you go to the article. Now, most primary care doctors and even the very busy Vertigo ENT kind of places would do it this way. So if you look at the three, Meniere's, benign paroxysmal vertigo, and vestibular neuritis, one of them comes with hearing problems. And then, of course, you do the audiometric testing, and or if ENT is accessible, you get the ENT to help you out since you're dealing with something that might be difficult to manage, even if you know what to do with it. So that's Meniere's, and so that's what they do. So they ask whether there's a hearing problem, and then if not, then they think about vestibular neuritis and or benign paroxysmal vertigo. So nowadays, they advertise the HINTS, HINTS. Actually, the best way to learn 30% of the material in these learning articles or in these lectures or articles would be to watch the video. Like the HINTS examination, watch the video. It's actually trying to figure out whether it's peripheral or central. And why is it important? Especially important in urgent care facilities and emergency rooms, because you have to figure out whether you're going to order a CT scan or MRI. And if you're a place where people are coming in with no other presentation that will tell you what's happening and just plain dizziness, you have to figure out whether you should do a CT scan or MRI. If you're in a Western country, that high resource developed Western country, then you also are worried about the medical legal part, meaning you don't want to get sued because you missed something because you didn't do a CT scan or MRI. And so this HINTS examination is fairly accurate and sensitive, and you can do this, and then if it says peripheral, then you don't need to order a CT scan or MRI. Of course, it's not going to protect you if something bad happens, but at least you can say that you based it on this examination. Now, you don't just do the examination, but leave out the important parts of the history. No matter what happens with the examination, if you have someone who has significant risks or indications that it could have been something else, then the result of your HINTS examination is not going to protect you well because something happened to the patient. Like, the patient actually ended up with a stroke or a bad neurological problem later on and you didn't pick it up. Okay, so what's the reason behind the quick vertigo kind of visit? They come in the clinic and you're in a hurry, and then you ask about the dizziness and it looks like vertigo, and then you send the patient home with some advice and give the patient medication, and then to tell you to come back in 1 to 3 weeks. Depends on how closely you want to monitor the patient. Of course, if you're more worried, you'll want to see the patient regularly. The reason for that would be the vestibular neuritis. The vestibular neuritis, whether or not you give medication, will get better on its own. And so you take that one out, so you're just left with a benign positional vertigo that doesn't get better. And Meniere's, but Meniere's is has a hearing problem. So if you have someone with a hearing problem with a vertigo, you immediately go for a Meniere's kind of workup and diagnosis. So you're just thinking of two stuff as far as the article is concerned. But let me warn you, in reality, there's much more clinical causes of vertigo, and it's not just those two. Okay, so it's not just vestibular neuritis and benign paroxysmal vertigo. So anyways, it's not getting better. So what happens next? Well, what happens next is if the ENT guy is accessible and you don't have time, or you're not too confident in the Epley maneuver, or you're not too confident in the home treatment exercises. So that's the BRANDT brand, Daroff, DAROFF exercises. And again, it's the best way to figure these two out, the Epley and the brand Daroff, would be to watch the video. This has something to do with the canalith from the semicircular canals. Okay, so moving those little tiny canaliths into the vestibule, that's pretty much what it is. So it's easier to learn from the video rather than looking at the pictures. In the old days, of course, they don't have the YouTube and the video, so you look at the pictures. But right now, it's so easy to watch the video, right? So what will happen is the patient keeps on swallowing the medication you give, but it doesn't work too well. Either the canaliths repositions on their own and they come back with no symptoms, but more than likely it's not getting any better, and then you think about doing the actual maneuvers, or you send it to the ENT guy. Now, if you find yourself in a place where the ENT is 4 hours away, it would be nice if you would try to learn it so that the patient doesn't need to travel that far, or that if the patient cannot afford paying the ENT guy and going to the ENT guy, which would probably cost 2 to 3 times more than what they're paying you, and this family and they're resource limited, and maybe it will help them out if you just sacrifice a few minutes of your time trying to do it for them and trying to educate them about the home treatment exercises, right? Now, of course, if it's really not working, you'll have to send it to somebody else who can help them out.